Dex feedback and things. Just to say apologies, as I mentioned, half term, I think note to self, next time I'll double check the dates. I think there has been an issue around who's actually around to attend, and I know it can be tricky juggling with things, but we do need a proper attendance certainly from our board team. So I'll take that away. Apologies, I have got apologies from Mark Vasalian, Banish Galia, Bev Messenger, and Hussein Haider Hussein, wrong way, because I know that they're all away at the moment. So I don't know if there are any others at all.
Yes, Doug McWhinney and Tom Daffron both sent their apologies.
Oh, lovely. Okay. Thank you very much. Are there any?
Here's Doug.
Ah, here he is.
That's a farm as well.
Oh, well, farm as well. Excellent. Good. That's good.
And just to say, Terry's giving his apologies, but I'm here.
Oh, sorry.
It's okay.
Beg your pardon. So we have got exec representatives. Now we have 3. Hello.
Apologies, colleagues. Flo took the best from us.
Yeah, no, we thought something had probably caught you just as you were coming. Your name tag is out. So I'm not sitting here on my own.
There.
We'll have a wingman. Lean over. Yeah, we've just gone through apologies. Any declarations of interest at all? Okay, good stuff. And minutes from the last meeting. Has anybody spotted any omissions or inaccuracies? No. Is everybody happy? We can approve those minutes? Yeah. Okay, thank you very much. And then going on to the action log. The first one, that was the draft Council of Governors Terms of Reference. That's been completed. Is it on the agenda for approval?
Yes.
It is, isn't it? Yeah. Quality. Lovely. And then the second one, number 22, around the Alzheimer's Society. This is the discussions we've been having around some training, dementia awareness, that sort of thing. Leslie's being roped into this slightly as well. We've booked a meeting with Jenny Page, I think it is, or Jackie Page, sorry, who's our dementia lead nurse, so that we can have a discussion, because obviously we want to work with the Alzheimer's Society, but we also want to see what we could do in-house as well, so that we can look at a whole raft, if you like, of potential training and development things, depending on what people would like to know and understand. So that's coming up shortly, I think, in the next couple of weeks. 15th November. 15th November. So we can bring it back to the council in terms of any proposals or suggestions. I mean, if there's anything in the meantime that anybody would like to suggest or has questions about, then please do drop us a line through Kwame. We can pick that up. So that will come back. That will certainly come back to the next Council of Governors, but I'm anticipating that things will move on in between. We won't be waiting 3 months or so before something's done about it, but we'll bring it back to close the loop and have that as an action phase. Any other actions that people think we've missed? I didn't spot anything in the papers at all. Yeah. Okay. Yeah. Lovely. Okay. Thank you very much. Definitely got a nameplate for you, but okay, action log. Chair's update. Firstly, apologies, this was circulated slightly late. I'm sorry, I managed to complete it in time. I have the papers are now circulated, so please do, if there's anything when you go back and have a look at it, if there's anything you want to raise with me. I've attached my update from the last board meeting as well in September. I do that just for completeness in case any governors weren't able to attend the board meeting, so that they have that update from me as well. But just to pull out a couple of things from the report that I've done for this time, is that I attended the NHS England Chairs and Chief Execs meeting in London, which was interesting. And as you can imagine, there was a lot of discussion around the Lucy Letby verdict and the impact and how that's going to be progressed and looked at in the NHS. Obviously, a lot of discussion around waiting list reduction progress, but also what industrial action and the impact that's having. And also in the summer, the NHS Equality, Diversity and Inclusion Plan was launched, which we're working through to come back with an implementation plan. In fact, that will be in January to our board. And on the papers that I've circulated, I've also given a link to that. If you're interested in looking at the plan, there are some sort of high impact actions that they're asking for. To be honest, some of the things we're already doing anyway, but it's helpful to have that guidance nationally. We had a successful interview process in September for the appointment of a new chief financial officer, which I don't think can you pick up on at all?
I think we can now. So we've appointed Johnson Dunk, who some of you will know, who worked here probably 7 years ago, and actually had Mike Keach as his deputy. So he's been around the block. He's been working in Leicester, work in Cambridge, and then work in Essex, and he'll be joining us, I think, not until February. But, we look forward to having him back again, and he joins the long list of very tall finance directors.
Is that the person's back?
He does have to duck going through doors, so he must be the wrong side of 6 on 6.
It was quite interesting, certainly on the interview day, because there were a number of rather tall people, and I felt it acutely. Just to say as well that we're very pleased Buckingham University have nominated one of their members to become a governor here for a link with the university. That's Professor Doug McWhinney. He's given his apologies.
So he hasn't.
I did wonder when you walked in, and I thought I won't ask in case I got it wrong. I do beg your pardon.
I apologise. The meeting is still running. We finished early, so I thought I could be.
Oh, right. Okay, well, I've heard the apologies. Tilly mentioned it, so I do beg your pardon. We haven't officially met yet, have we?
That's a fair enough reason not to know.
Yes. So welcome, and thank you very much for coming along. It's great to see you. We look forward to working with you, and hopefully you're getting all the bits for your induction. Although I know you know the hospital.
Doug's been around a bit.
Yes, as of old.
Thanks, sir.
Yeah. That's great. Just to say as well, there have been some great events actually during October as well to celebrate Black History Month and also Freedom to Speak Up. There's some quite a bit of raising awareness around freedom to speak up from the Guardians. And also we've had some great events, a couple of events in the tent as well, celebrating diversity. And we've got another event, I think, on the 31st of October. And there was a great presentation online as well about some inspiring women who have gone on to great things in various organisations around the country. And they were encouraging and talking about their experiences getting to sort of positions around medicine, psychology, research, all that sort of thing. So it was, I sat in and listened to it. And it was a great event. So it was really well organised and really positive actually. And hopefully things will carry on from that and snowball. I also visited the robotic assisted surgery theatre again, this time to actually see. I'd met the team, but I hadn't seen any of the surgery, and it's quite extraordinary, and the skill set is amazing. So it really is very inspiring. They're an extremely well functioning team, and I know that we're hoping to expand all that. And also neonatal services, because they've been making some changes just to try and make the best use of the space they have, which is not brilliant, but until we get our new hospital built. So that's just to give an overview of some of the stuff I've been doing since last time, or since September when we had the board meeting. Okay, is there any questions at all? Thank you very much. I've also then got to, this is 2 items for noting. This happened earlier on in the year. We had the reappointment of Hader Hussain as a second term as a non-executive director. That was circulated, I know, to get council's approval, and also to note the reappointment of Maxine from Health Watch. So that's the sort of governance side we need to tidy up. Okay, Chief Executive.
Thank you, Alison. Just to apologise for lateness and be that Yvonne and I will actually about 5 o'clock for other meetings. So I don't have a lot to say. I was going to to brief you on an initiative that we started, and actually Alison touched on it. This is about outpatient waiting time, because they have been getting progressively worse. We have a target to meet, which a few years ago would have been absolutely outrageous to even think of it, but we have a target to meet that nobody waiting more than 65 weeks by the end of the financial year. And at the moment, left to our own devices, we will be a long way away from that. So we started an initiative to look again. We've had all sorts of problems. A few years ago, you may remember we made a decision to try and move to full booking. Jackie Page is there, and I think it's she will remember and probably disapproved very strongly in extolling the virtue of partial booking. Partly because we had lots of doctors' strikes. So when you have full booking and everyone's booked, and then you have to cancel the whole day because of, for example, doctor strikes, and then rebook patients in, you find that somebody perhaps who's waited 30 weeks now has to wait another 30 weeks before they can be seen. And so we have a lot of patients who are out of order and are being needing to be wait a very long time. So we made the decision to take a radical approach, and we are going to cancel lots of patients who have waited only a moderate amount of time to free up sufficient slots to deal with the long waiters, to bring a bit of equity to the situation. It's important that I tell you this because I'm sure you will hear quite a lot of chatter out there in the community, either from somebody who thought that, you know, they've only waited 15 weeks and this is too bad, now they've been cancelled. But it also it brings some equities and fairness into our waiting position, which I think is needs to happen. So we are expecting now to be able to meet our 65-week, certainly for the non-admitted patients, by the end of the year. We're also going to start sending out some patients to the independent sector who have some capacity, and I've used 3 examples of this. We are sending some varicose vein work, and these aren't cosmetic varicose veins, these are quite severe varicose veins, to a local surgical centre in Milton Keynes. And we're also going to start, or restart actually, sending out some cataracts to Spa Medica in the Bedford town, and we are going to continue sending out some glaucoma work to Hammond and Summer, who are a local optometrists in Milton Keynes. And we may look to send out some other services just if they have capacity to work. So that will be taking place over the coming weeks and months. I'm very happy to answer any questions or drag on into answering any questions if anyone has something particularly difficult.
Any questions from anybody at all?
I mean, just a comment. I mean, that whole kind of thing about how we approach the long lips, I think, is very welcome. I do recall in another healthcare setting hearing a discussion about the potential of looking at people's individual characteristics rather than time in order to affect. So is someone still working? Those kind of things. Now that then makes it more complex, but that's something we could be thinking of.
So the answer is there are 1 or 2 health communities, and in particular, I know that Coventry and Warwick are looking at this.
Yeah.
It is something to aspire to, and this makes the difference between bringing proper equity rather than equality into the waiting position. Yeah. And if you're waiting for an orthopedic procedure and you're a bricklayer, then it may be more important to you than you have a sedentary job. Yeah. And we also know, some of the work that we've done has shown us, that if you're in an area of deprivation, you, for reasons we don't fully understand, often do end up waiting longer than other people. So it's something we certainly aspire to. I don't think we're in a position to do it now because we've just got so many people waiting. Yeah. But I think it is absolutely where we should be heading. So at the moment, the waiting times will be ordered in terms of clinical priority, either because they're sitting on, I say, a 2-week cancer pathway, or we know they've got cancer and they need various diagnostic methods and their treatment staff, But if they're routine patients, right now, we're just aspiring to treating them in the order that they arrive, rather than dipping down and looking at their individual circumstances. But you're absolutely right. It's what we should be doing. And we've had a couple of presentations abroad about this. We're not yet in a position to do it.
Okay, thank you.
Just going to say, I mean, I agree with what William says, but I also understand that it's extremely complex. If you start having all these variables,
Yes.
it's very difficult to have guidelines for staff. I can think of an example in terms of hip replacement. There were two patients, one was working part-time in their early 40s, the other in the early 30s, wasn't working, had two young children, lived in a maisonette without a lift. And that particular hospital had a criteria that if you were in paid work, you went ahead of the person that wasn't. But actually, the person that was in maisonette with two young children needed the hip sooner. And you can't do that in a system of.
You either have to know an awful lot about
Yes.
or you have to be driven by a certain number of rules. And I think the other thing, which interestingly, the Health Economy and Commentary has done, they've started testing this for acceptability with general public and people waiting. And there isn't universal. Yes, sorry, you go ahead of me. I can see that your need is greater than mine. Actually, it is quite complicated what people are prepared to accept, because of course it's rather like going to A&E and seeing all the patients all ahead of you. You don't know what's wrong with them, and you're just hoping and assuming that they are indeed much sicker than you. You don't really like it.
I know there's got a question from Yolanda actually, which I said I'd raise. She's just asking whether the pathology reporting waitlist is prioritised as much. She said our backlog will only get worse, especially when colleagues leave. We're told they won't be replaced to save money. I do understand that reasoning. It just doesn't always seem this department is considered as much.
So we have reporting standards for pathology for urgent work, which I think is 2 weeks, I think, and histology, and I am assuming Yolanda's talking about histology. Currently meet over 90% of that reporting standard. In terms of urgence, they can wait longer. I am not aware of any significant reporting issues that get in pathology that have been brought to our attention. Actually, maybe one of the best informing departments in the hospital in terms of meeting their waiting times. But Yolanda, if you think there's a problem, please drop me a note outside and I'll have a look at it and come back to you.
Thank you. Any other questions? Yeah. Okay. Thank you very much. That's that update. And capital programme updates.
Capital programme, I'll take that as well. Thank you. So we've got a report, a nice colourful report showing progress against all our capital projects. If I just pick out 2 or 3 of the big ones coming up. So we're just starting work in Lloyd's Court in Milton Keynes, which looks opposite the main shopping centre. I think probably next is the biggest shop, pretty much was it, where we are converting a very large chunk of office space into outpatient accommodation. I think there's going to be something like 30, 40 talking rooms there. And that will be complete. Probably it'll just miss the end of the year. It'll be at Karen, it'll probably be the end of April, probably before that's complete. But it'll be a fantastic facility for at least ophthalmology and hopefully 1 or 2 other services as well. We're also starting on our decarbonisation, which is partly grant funded. And this is going to replace Windows in phase 2. As well as some air handling plant in theatres, HSDU, and I think a couple of awards as well in phase 2, which will allow the hospital to become much more efficient in its use of and we're also taking part in something which I hope will be successful, which is what's called the district heating scheme, where Milton Keynes would circulate around a large chunk of Milton Keynes some hot water for businesses and homes to pick up on and use rather than heating water with gas. That's something which will probably take 18 months to come to fruition. For hot water, those of you know, milk as well, up by the BMX track and helicopter landing pad right in the north of Milton Keynes, a giant water treatment plant just past the lake. And part of the treatment of water, a lot of heat is generated, and they recover the heat from the sewage tanks to convert into hot water. They distribute hot water at about 85 degrees centigrade all around Milton Keynes, and it's a terribly efficient, sustainable way of generating hot water. It goes to Water Council, state, well, the Housing Association states as they are, but they also want a few big businesses like us who consume lots and lots of heat all the year round to make it worthwhile. And just mention one more is we're just about to start converting Milton House, which is, if you look at the doors area on the right, into more clinical space, moving out people out of that area so that paediatrics have more clinical space, which particularly paediatrics use clinical space over the winter. So that will help them going forward until such time as we can move them into the new Children's Hospital. Happy, however, to answer questions on any part of the capital program.
If I may retract from Sue, I'd like to ask about Lloyd's Court.
Yes.
Parking facilities for the 24 something of the patients and for the staff to get in.
So there's a large amount of usually quite empty car park immediately outside. It's all council car park in the sense that it's in purple zone, again, for people who don't know the key. So it's actually probably cheaper to use than the hospital car parking. We are getting the council to increase the number of disabled spaces immediately outside, but there is plenty of car parking, and I think there's also, of course, plenty of buses that go in that direction because of the shopping centre. So there's lots of centralised transport. So for members of the staff, they will be treated like staff at Wooden Gate, where we provide a council permit for them to park free of charge in the purple zone.
May I comment?
You may.
I'm happy with the answer. However, as we all know, the shopping centre is gridlocked from the 1st of December.
So that was certainly true before COVID. I think it is less true post-COVID. But majority of our appointments are during the week, not weekends. In fact, there aren't any appointments currently scheduled for weekends. Whether that continues, I don't know. So during the week, generally speaking, it's always possible to park there. If that becomes a problem, we'll have to see what we can do to help the problem. The expectation is that there should always be parking in the towns that we actually operate the facility.
You're clearly an Amazon man.
You'll see this chart.
Any other? Yes,
On two, please. The first one pretty straightforward. The chemotherapy car park extension. I mean, talking about feasibility, obviously is a very constrained site.
Are you asking where it would work? How is that?
Yes, how is that going to work in that very?
Okay, so actually, if you go into the car park and you turn away from Cancer Centre, there is an extension that people with long memories we built probably 7-8 years ago, something like that. And if you look north, so back in the direction of the top of the site, there is a big triangle of land which currently has a big ditch in it, and some rough land. We can fill that ditch in and use an extra 20 or so car parking spaces up in that corner. I'm hoping we can also relay out the car parking spaces, which isn't actually terribly efficient. So I'm hoping we can do somewhat better as well. And I'm also hoping that the PET-CT van, which is causing an almost permanent irritation as it takes up a number of disabled spaces outside between Milton House and Oak House, that as soon as we get rid of the contractors on site, we're hoping to move it so that it will slot into the the entrance that the contractors currently use as their radiotherapy entrance. So it will be closer to radiotherapy. We'll plug it in there. We have, you may not know this, but we have to provide a special toilet for the PET CT because a small amount of radioactivity is given and has to be dealt with separately and specially. And we know that because the contractors currently have their site set up there, that they have access to electricity and mains range as well. So we should be easily possible for the toilet facility.
Okay. The second point then relates to the radiotherapy centre. I noticed you say something about OUH happened, not yet confirmed about the procurement of the CT on the.
So I think
I'm slightly concerned that I'm sure you are as well.
so. I'm no longer concerned because we have now agreed with Oxford that they are going to procure and purchase the planning CT, and as well as the linear accelerator. So I think it will be a difficult sell because the building will be substantially complete by Karen again, probably let's call it May. And then the linear accelerator will be installed. And then we will go through this sort of really irritating wait period of up to 18 weeks while the physicists sign the linear accelerator, but the building will look complete and the general public won't really understand why we can't just go in and use it. But the physicists really have to sign the machine off in terms of how it is performing so that we don't do anybody any more damage than we intend to do.
I think what I was slightly concerned about was the second sentence talks about slightly change the scope of the project. Now, clearly that's no longer the case.
So the scope of the project, so originally we were going to purchase the planning CT.
Yeah.
But because Oxford have got the managed equipment service, which they use for all their linear accelerators in the Churchill Hospital and at Swindon, they decided it was more economically advantageous to add these two machines to that service. And so we're perfectly happy with that as long as somebody buys it. So that will take place. And the reality is that it probably won't open until towards the end of summer next year, but that's because of these technical tests set up.
Okay, thank you.
Very much. Thanks. Any other questions? Okay, thank you. Next one. Just going on to item 9 then now is the board committee updates. As agreed with the council of governors some time ago, obviously our chairs of our subcommittees give updates a couple of times a year around what's happening in the committee. I suppose what I would do, hopefully if there are any questions, I will try and answer them, but the chairs of the committees have given their apologies because you can't be here, and I can always go back to them and get them to give you an update if there's anything that I can't answer, but hopefully we will be able to. And I notice Heidi's online as well, so I can always confer with Heidi for any questions. But just take the first one, and that's the Charitable Funds Committee. It's a very comprehensive overview of what's been happening there. Are there any questions around the charity? Of course, William sits on it as well.
I think the only thing I want to highlight is clearly one of the consequences of the OUH decision was potentially the shift, because the original intention was that the appeal was going to be looking at buying a bit of equipment, and then we then shifted to that being a wellbeing hub. So and that's very much the focus now. It's just, I think we're still at the stage where we haven't yet sort of seen that sort of fleshed out beyond that initial thought. I know at the last meeting there was a reporter saying that was going to be coming up very soon, because it's all very well to say wellbeing hub. We need to have some more kind of
Sure. So
more granular.
I can speak from a building position, but we are waiting for the cancer team and the charitable funds team to agree a specification.
Yeah.
This is likely to be a freestanding building in the garden of somewhere between the cancer centre and radiotherapy, not exactly sure where.
Yeah.
Rather than a part.
Rather than integrated. Okay.
Inside, so it'll be probably of wooden construction, and from what I've heard, it's likely to have some meeting space in the kitchen, so some quiet rooms as well. but specification hasn't yet come through to the building team, if you will.
Yes, I think that's what it was sort of, focusing on, because clearly we need to have some kind of understanding of what the specification is, what's the range of things that's intended.
Yes, and also how it is going to be staffed, because
Yes,
to be useful and helpful, there has to be something in there. Might well be part of a volunteer team, because there is a current expectation that paid staff will be in there. But we haven't, again, it is important to understand so that we can make sure it's open and safe, but there are sufficient people about.
I'm sure we'll be coming back.
yeah,
To chat about this.
next meeting, I think.
Yeah.
Yeah.
Absolutely. I see Rachel has got her hand up. Rachel?
It was on the same subject actually, and just wondering whether has there been a timetable for the Wellbeing Hub put out into the sort of public domain? Are there expectations around timetable at the moment or not?
So I know, practically speaking, without a specification, it can't be designed, and therefore the reality is no, that there is not a current working assumption in terms of when this will be available. The reality is probably it is going to be a pre-designed, prefabricated building, if you will, then perhaps we could be talking about 9 months from somebody giving me a specification to installing it. If it's going to be a bespoke special build, then possibly a bit longer.
Oh, okay, it was really just about managing expectations. If something's gone out saying, actually, this is where the sort of timetable, obviously that hasn't been the case, so it's not so much of a deal.
I think as well, Rachel, because there's been some fundraising around it as well. I mean, I've been involved in a couple of events. So, and I think from what I can remember, we weren't specific around when it would come into being. But obviously that we needed to have the funds, so we were ready to go as soon as the facility was available to us to furnish or refurbish. So yeah, as far as I'm aware, there's nothing specific. Yeah. Catherine.
Hi. So also about the radiotherapy centre. To do with the fundraising appeal, it's highlighted a few times that we're not sure if we'll make the targets. What is the impact if we don't reach the target for that?
So, put rather brutally, which is my style, either the building will be a lot smaller, or it will have to be channeled into some other development. So, depending if the charitable target is, not met by 50 or 100,000 pounds, or not met by hundreds of thousands of pounds.
Yeah.
Okay.
Yeah.
I take it it will also be affected by the specification, right? Because it may be that you're able to find a cheaper way to produce the Wellbeing Hub. But
so inevitably, the building will have to be designed with cost in mind. So if £400,000 is raised, then we'll have a £400,000 building, and we will have to manage the services in light of what can be afforded.
yes.
Yeah. It's a good point, actually. Yeah, and probably something we could pick up with to keep an eye on in the charitable funds committee, actually.
Yes, absolutely.
That's a really good point. Thank you, Catherine.
Nice.
But how much has been raised?
I knew somebody was going to ask that.
Well, that's the answer.
I don't know.
I know the Friends put in 50,000 and you raised 65,000, was it, like the goal?
Yes.
Yeah.
Yeah.
Nick's got his hand up. Is it around the funds, Nick? No. That's not okay.
No, sorry, I pushed the wrong button. I'm sorry.
Well, that's handy.
Well, I mean,
Knows the answer.
those two things together, we're already over 100,000.
Yes, I know.
I'm not aware of, I think, without having a finance report, I'm not aware of
No,
what the current figure is.
I think there've been.
There-
I know one
Yeah.
donation from an organisation as well. So that's
I
pushing.
know
it
that
up.
SMG and team are working very hard at
They
it. So,
certainly are. Yeah. There's huge emphasis on getting the money for the wellbeing. Rachel.
I spoke to Vanessa quite recently, and she said there was just over 300,000 left to raise.
less.
Oh, less
space. You got that the negative way.
We're up 200 then.
Yeah.
Good progress. Then.
The reality is we could build a building for
200.
200,000.
Yeah.
It is a question of whether or not, for example, we're going to install toilets and take, all the
All right.
the sewage out there.
Yeah.
So, it sounds like there is sufficient money in the pot to build something, but it has to be useful or it's not worth building.
Yeah.
And so the cancer team and in consultation with service users,
Yes.
need really to reflect on whether it's a summer house at one end or a fully functioning well-being hub at the other end.
Yeah. Laughing.
Every year.
A large.
They're rather nice, actually. Thank you very much. Any other questions?
Is the meaningful activities facilitated at substantive post now? Because it says it was going 722 that started to look at it.
So no, it's not. We have a person in post. He's been in post for about 4 weeks doing a magnificent job. But in terms of its substantive nature, we need more time to work through that. So he's on a fixed term contract for a year while we start to find that funding. But the evidence even after 4 weeks is that it's an important piece of work.
I think the essential point is the executive has to approve whether or not it's going to become a substantive post, and that's obviously looking at a number of factors in order to be able to do that. But I think we're now in the second year of it. That the charitable.
Well, we've had it. We've had it a couple of years now.
They started looking at
Yeah. So.
Leslie.
As a new governor, what is a meaningful activities facilitator? I mean, I can imagine.
So interestingly, it's an individual who will visit the ward areas, with a particular focus around our patients who have maybe dementia or learning disabilities, but it's not confined to that. And in order to keep people safe and settled in the hospital, we'll engage in particular activities. So it could be painting, drawing, it could be using particular toggle gloves. It could be singing and music. It is a whole. It's actually really based on the needs of the individual, but we'll also take in the ward as well. So it's making sure that people are not disengaged in hospital. That they're it's not really. So I was going to use the word entertained. It's not really about entertainment. It's about meaningful stimulation and challenge. And
it's interesting that you say it's particularly people with dementia and learning disabilities or whatever, because I've been very aware a number of older people I know have been in hospital recently, and they don't have sort of laptops or anything like that. There's no televisions. They're just sitting there. They have no stimulation. Nobody talks to them except unless they have visitors. There's no stimulation for them at all. And to be honest, they might go improve as a result of being in hospital for whatever they went in for originally, but they go downhill in terms of their ability to actually do things. And so it really shouldn't. I mean, I think older people need.
That's their two particular groups we would focus on. But it is all patients. It's not just about people with learning disabilities or people with dementia. It's the one of the advice.
Yes. Yeah. But the idea is that it covers every the needs of all patients.
Yeah.
I mean, I think it's important to stress that what we've got is something which classically charitable bits of organisations do: test something out. If it works, and then look at how you can continue to fund it. And that's exactly what we've been doing.
Yeah.
And it's very much a question. We're at that stage and it actually be transferred and embedded into a clinical structure, because we're talking about something which is a non-clinical focus.
I was just going to ask what current capacity there is for that.
One staff, one member.
One staff member, but just in line with the conversation we've just had. So while there will be activities for individuals, there is also the group. So we will be bringing together groups of patients, like for the example is painting or whatever activity that it might be, like music and dance. So there's some group work as well as the individual. So the individual who's the meaningful activities coordinator is actually coordinating the wards to embed some of these processes. So it's not as transactional as it sounds. It's trying to get this embedded across the whole field.
Is there some support going to be, I think you support the MK Health Arts or Hospital Arts?
So that bit doesn't connect.
That
It doesn't connect. No, and it's quite clinically orientated. So it's not entertainment. It is about meaningful engagement while we're in the hospital.
Well, I think his work is around well-being, which I think is technically clinical.
Yes.
So Arts for Health, which is they do run a number of courses for people with Parkinson's and dementia and other. They're mostly outside the hospital for patients. And there are a number of other groups that obviously support staff and support patients, both volunteers and chaplaincy and other services who operate in a slightly different way, but do provide some input. And I think it would also be nice to as we go forward, we think about the new hospital, which is going to be exclusively single rooms, which actually can be more isolated for patients. How we manage to provide enough stimulation for them. So it's something which we haven't started yet, but it'd be great to get some input about what would be considered best practice, because although you might recover better because of management of infection and dignity and privacy of having your own room, it can also be isolating. So how we manage that is something that we need to address going forward. If anyone has a view, it would be great to start outing some of those views.
Any other questions? Okay. Thank you very much. So that was a charitable fund slide, wasn't it? Workforce and Development Assurance Committee. Did anybody have any questions from that summary about the work of the subcommittee?
I've got a question about this DAF survey.
Yeah.
So it's that the trust continues to go high on bullying and harassment, and this actions being undertaken. Can we get some more details about those actions?
Can certainly bring some back. Yeah, absolutely. Yeah, we'll make a note and get those on. There's a lot around sort of team development and that sort of thing going on, Shirley, but we can get the details. Any other questions at all?
Just a comment. I mean, it's really positive to see that.
Sorry, just bring.
Oh, sorry.
I was going to ask about the apprenticeship levy, because I was wondering what roles that might cover and whether that might help with encouraging local people to take up roles, more clinical roles. I don't know whether it covers clinical roles or not.
So it covers probably the vast majority of the levy is focused around clinical roles. So a significant proportion will be, in fact, we've got 18 qualifying in January, will be healthcare support workers who enter into the apprenticeship. We support them to become nursing associates. The next bridging part for us is from nursing associate to registered nurse. That's the degree nurse apprenticeship. But there are some of the clinical roles where we haven't made, this is probably more of a national problem, is that it's looking at those the therapy roles and how we can exploit the therapy roles using the levy, and particularly drawing from our own staff opportunities that we can create them. It is also broader than just clinical roles. So we have administrative roles, which we'll have both in corporate and in clinical teams. So that gives opportunities for young people in our communities, as well as the clinical component. But we run a cohort roughly of around 20 clinical apprenticeships every year.
There's also quite a few sort of like admin ones, so management degrees as well.
I was just concerned it was just admin, and now we have to hear it's clinical as well.
Thank you. Well, make a note and come, well, get those details to government around the actions, some of the actions that have been taken. Okay. John, do you need to be here for the launch of the MyCare portal?
I probably don't, so Paul and I just disappear, because Jackie has a fabulous presentation. And he's going to wow you with our portal. You just tell by how she's beaming on the face.
That's great, thank you. Thank you very much. Carry on now. The Inclusion and Leadership Council update. Again, apologies, I think this came out after the other papers as well. Again, it's in your pack, so if there's anything that you want to ask when you've had a chance, if you haven't had a chance to read it already, but I'll just pull out a few things that have been happening since the last report. Certainly around the agenda, we've strengthened that, so there are stronger links between the council and the trust board. It's obviously a direct link from the networks, staff networks, which in fact are building now, and we're increasing their number. We have had a request for a neurodiversity network, which is being hopefully pulled together, and also for a carers network as well. A lot of people who not only work in the hospital also go home and put carers there as well. So it's very important that they're supported. I think we mentioned some of the staff survey action plans, but there was particular work with the Ability and the BAME networks around the Workforce Race Equality Scheme and the Disability Equality Scheme. So again, the idea is that there is much stronger partnership work with staff groups around these pieces of work that are set and come out with action plans so that people agree and are on board with what's proposed. Vanessa Holmes, our charity lead, she now also links in with the Inclusion Leadership Council. It's great because she's already been looking at, and I think has flagged up some external funds that we're not able to access to actually support our networks. Which is great because although we've been able to give them some funding, as I'm sure you all appreciate, money is incredibly tough at the moment. So if we can source any from anywhere else, that is a real bonus. And I mentioned the Equality, Diversity and Inclusion Plan earlier. We're going to have our own implementation plan presented to the board in January. And also it was raised that people are aware of continual professional development funding for clinical staff, but wanted to see what might be available for non-clinical. A lot of staff are very keen to develop themselves further, so we're looking at that as well. There's some really good stuff as we get more established. There's some great stuff coming in from the networks, which obviously we're trying to work with them, but also look at other avenues where we can support some of the initiatives that have been proposed. So, but as I say, please do come back to me if there's anything else that you think of or would have a question about. Thank you very much. Allyship, apologies for this one, it's had to be moved to the next meeting. The member of the team who's this is their remit, if you like, unfortunately they're not working at the moment, and we're hopefully getting them back soon, and that will be picked again. So we will bring that again to hopefully the next meeting.
May I ask what does it mean?
The
allyship,
it's part of the sort of cultural development work that we're doing, and it's around particularly with BAME network as well, but it's around members of staff in the organisation being allies for everybody, for each other. So the idea is that, you know, if you see behaviours that aren't appropriate, and that's, you know, could be with somebody with a disability as well, you know, anything like that, then another member of staff would speak out against it and be an ally to that individual. I mean, that's one example, but there are, yes, it's possible to be allies in all sorts of situations. But it's to try and ensure that we have that culture where we all feel responsible for each other and supportive of each other. So it's a big aim that would make a huge difference if we can establish that through the organisation. Okay, thank you very much. So now, Jackie, I think we got to your item, the MyCare portal.
Right.
I'm just wondering. I think we've got some papers, haven't we, in the pack? Is that right? Are you speaking to that? Yes, to the presentation that's been circulated to everybody. Yeah.
Yes. I've also added into the presentation a little demo of the actual patient portal, so I'm hoping you'll be able to see that on the screen as well.
Oh, right. So, colleagues who are facing with their back, do you want to turn around just so you can see?
It's just looking.
Can I just check you're able to see that?
Yeah, is that brilliant? Yeah. Yes, that's lovely. Thanks, Jackie.
Okay. Well, good afternoon, everyone. My name's Jackie Page, and I'm the Digital Solutions Programme Lead here at the hospital. Thank you for giving me the opportunity to come and present to you the new functionality available in our patient portal. The screen that you can see now shows the welcome page for the patients to register and log into. This screenshot also shows on the left-hand side the additional way of accessing the portal using the NHS app login credentials. This was a feature added late last year, and we were one of the first hospitals to enable this feature. So we're quite proud of that.
You're on mute, Jackie.
Have you got me now?
Yes, thank you.
I'm not sure how that happened. Apologies. Okay, so in July this year, Milton Keynes Hospital, Cerner, our hospital electronic patient record provider, and Induction Health, our patient portal provider, teamed up to offer patients more functionality in our hospital patient portal. So the new functionality comes under the name Healthy Life, and it offers our patients access to messaging between clinicians and patients. And where the clinician has permitted it, patients are able to message them back. Where appropriate, patients are now able to complete a questionnaire prior to their outpatient appointment. So we've worked with the preoperative assessment team at the moment to be able to provide that. And also patients now have access to their results and any reports. So textual reports, such as blood tests, are available immediately. And any results requiring written reports, so for example, radiology and pathology, are available after 21 days. This new functionality nicely complements our other available features, which include appointment management, the ability to be paperless, having access to patient leaflets, receiving text and reminders for appointments, being able to view discharge summaries, and access patient surveys, including the friend and family test. And the screenshot you can see is actually the home page. Okay, so patients clearly like using the patient portal. Since we went live in February 2018, we've had about 160,000 patients registering for MyCare patient portal. And in recent months, we've had over 2,800 patients per month registering, and of those, 75% have chosen to be paperless. Since we went live with the PPU Healthy Life functionality in July, late July, we've had 26,000 patients logging on to the Healthy Life portal to view and use the new functionality. And to just give you an idea, this is the portal usage since the 25th of July. And as you can see, patients are really appreciating being able to review their results detail with over 270,000 instances of use. So the other useful thing to notice here is the messaging inbox, which is showing that patients and clinicians are actually viewing the messages that they're being sent. So I've just, hopefully you'll be able to see this quick demonstration. It's only about 2 minutes, so it doesn't take overly long. So I'll just start it off. Okay, so the first thing I'm going to show you is the home page, which is what patients are presented with. Then we're going into secure messaging. As you can see there, any messages that haven't been read are in bold. And in this particular case, the patient is able to message the clinician back. So the next thing I'd like to show you is results. So we're going into pathology results that are available straight away first. And you can see patients are able to choose the dates that they look at their results. And then these are the results that are available. If they're a bit unsure about the results, they can click on About My Results and it gives them a bit more information about the test. So then if I show you quickly the radiology results. So these are the ones, if you remember, there's a 21-day delay. So you can see the first one is pending until the 14th of November. And then after that, you're able to go in and download through your device your report. So just showing you now what that looks like. Okay. And then finally, then we go on to the family history. So if any patients have got any family history on the system, it shows up in this area. And we ask that if there are any corrections, that patients go and talk to their care team to be able to get them corrected on the EPR. And finally, I'd like to show you the questionnaires quickly. These are working currently in pre-op assessment. You can do the questionnaire whenever you like at home. You can stop and start it, and then you assign it. It goes through to your clinician, and they are then check it before it then goes onto the electronic patient record. Since we started, we've had 75 to 80% of all the questionnaires that we've sent out completed. And then this is an example of the questions that are asked and how easy it is to complete them and fill them in. So that is where we go back to the home screen. Just to talk about a little bit about future functionality, we're developing further patient questionnaires with the cardiac rehab team and maternity at the moment. Going back to something John was talking about around outpatients, we want to involve a waiting list validation, where patients will be asked if they still require their appointment, and their answers will be fed back into the electronic patient record. So we've got a full validation trail, or full audit trail, really, I should say. And then we're looking at making it easier to have video appointments. We've got a system at the moment that's a bit clunky. This new video appointment system will be accessed through the patient portal, so it should be an awful lot easier for our patients to use. And that was my whistle-stop tour. I hope I haven't gone too fast, but I know we're sort of short of time. And is there any questions?
Thank you very much, Jackie. That's really interesting. The numbers are incredible. Shirley.
So I logged onto this, and I saw on my record that it looked like there was a whole load of letters from quite some time ago when I had some video treatment. But when I clicked on them, there was nothing there. There was nothing opening up. So how far back is this actually going?
I think it depends when you actually log on and you've signed on to the, when you start going on to the appointments, or when you start logging into your portal. But I can certainly go away and come back with a more definitive answer if that would be helpful.
Thank you.
Yes.
I recently had an appointment in the hospital here, and I'm on the MyCare system, but it never got on the system. The appointment on the MyCare system. My previous appointments were, but not the new one. It'd been done through the GP, and there was nothing on there, so I got no reminders or anything, because I questioned it before, and then I thought, yes, I had registered quite a few years ago when it first came out. So when I was in the GP surgery, I asked the receptionist if anybody had any problems. And she said, well, on her basis herself, she had recently had problems not being able to find things on the MyCare system, her appointments. So I don't know whether something's not quite gelled with the update.
So I think
my appointment was on the 12th of October.
At the hospital.
At the hospital.
Okay. If you could just perhaps send me details separately, I can have a look at that. It's certainly not something that I've heard of a lot of, so I don't think it's a blanket problem, but it'd be certainly useful to look into it for you.
Yeah, okay. Because would you like me to ask the person in the GP surgery to send you something as well?
Yes, I'm always very happy to look at any issues that we might have, because we obviously want to make sure that we don't have any. So yes, please.
Jackie, is there a sort of a help button or something, or contact details, or is there in the portal itself?
So, yes, in the portal there's a help and support, but clearly what the gentleman is describing would be an issue perhaps with the hospital appointments. So probably best to come through. There is an inbox, or you can get through via communications. They send information through to me when patients get hold of them.
Right. Okay. Leslie.
Has any research been done on the patients who don't use the My Portal or access it? Because it seems to me that if everything is going in that direction, there'll be a small number, but of people who will lose out. And as a result of losing out, they could become even more isolated than they already are. So it might be worth
Okay, so nothing that we do on the portal is different to anyone who isn't on the portal.
Sorry, Jackie, I think somebody's got their volume wrong.
Yes. Not quite
Is it
sure.
anybody on the laptop with a?
It's Gary, he's on mute now.
Oh, it was Gary. All right. Okay.
So nothing that we do on the portal is different to anything that happens normally. So when you sign up for the portal, you're given the option to be paperless. If you don't want to be paperless, then you can still be on the portal and receive letters. So there is no difference really. We do quite a lot of focus sessions, and we advertise these on social media for patients to come and talk to us about any issues they might be having, staff as well for that matter. They're very popular. We've got another one coming up in November. But I mean, we've had a lot of experience with patients. Obviously, we meet an awful lot, and we've got some people in their 30s and 40s who really don't want to know or be part of the portal, which is fine. Then I have a lot of people who are in their 70s, 80s who are really interested, and were particularly interested in the portal use, the new results and reporting functions. So it's really difficult. You can't draw any conclusions. It suits some people, it doesn't suit others. But as I say, we don't treat our patients differently.
Thank you. Thanks, Jackie. Gary, Gary and then Maxine.
Hi, Jackie. Can you hear me?
Hello. Yes, I can.
Couple of questions, really. One is the app and the format standard across the NHS? And the linked in question here is, what happens if a patient's treatment spans more than one hospital? For example, I'm thinking about pathways that lead through to Oxford on cancer and things such as that.
Okay, so I think somebody needs to mute. Yeah. Okay, so thank you. This is the Milton Keynes patient portal, and so it's to do with all things Milton Keynes. What we are doing a lot of work with, which I mentioned right at the beginning, is the NHS app, and the NHS app is aiming to work with all of the hospitals who've got portals like ours and bring it all together, just so we can deal with the issues whereby you're going from different hospitals to different hospitals. At the moment, it's all been very disparate. We are quite far ahead of the curve with our patient portal. There are others who haven't really got a patient portal at all. The NHS's app is trying to bring everybody up to a level. So if you actually go into the NHS app and go into our portal, you won't have all the functionality that we've got now. The NHS app is trying to catch up with, well, if you like, where we are and some other hospitals who've got a quite mature patient portal.
Thank you. Thanks, Jackie. Catherine.
Hi, just curious. So you mentioned about messaging between clinicians and patients. How many clinicians have chosen to be contactable on the system?
So I don't have that level of detail at the moment.
Okay.
We've only just got hold of some of the detail which I've shared with you today. There was an awful lot of nervousness around messaging between patients and clinicians, or sorry, patients messaging clinicians.
Yes.
But I know of at least 3 clinicians who are messaging their patients and are happy to have the messaging back, and they have been very appreciative. There was one which Debbie Phillips, I think she forgot to tick it or something, that you have to tick to say you're not worried about having a response. And she was texting a young man, a teenager, obviously over 18, because you have to be over 18 to do it. And she was very gratified to hear that she had a thank you message back and thanking her for all the care that she'd taken from him. So she really enjoyed that message. So I think there's a lot of nervousness, but it's not turning out to be the problem that I think clinicians thought it might be.
Okay, and would that, when you say 3 people who've heard anecdotal data from, is it out of 10 clinicians? Is it out of 100? Is it more than that?
Yeah, so I mean, it's all our appointments, all our appointments through RPAS, our patients are able to access the system.
Okay.
those are just the clinicians that I'm working with. I think we've got to remember that we only went live with this the end of July, beginning of August, so we're still part of an education and improving cycle.
Okay, thank you.
Thank you very much. Thanks. That's really interesting. It's yes, I mean, it's the way services are going to go, isn't it? And how we interact with each other going forward over many decades. Oh, Maxine, sorry.
All right. I just had a question about accessibility. I noticed, sorry, I went in while we were talking. Having things available in different languages, particularly. Also, we've been getting quite a lot of feedback from BSL users about difficulty arranging interpreters, and if people are receiving appointment letters through the portal, is it easy to then arrange interpreters? It is thinking about that interface with managing that as opposed to having to then call the hospital. Just thinking about what the future holds for the accessibility of the system.
Thanks. That's a really good question. Jackie?
Yes. Okay, so we've had quite a lot of dealings with our supplier about accessibility. I don't think they've been quite there as far as we would like them to be. Again, we are sort of groundbreaking in all this, but there's absolutely no excuse for not taking that into account. The NHS app is also forcing more of the suppliers to think along those guidelines. We do have some patients who have problems with sight. They're using it and they're able to use the software on their PCs and so on and so forth to be able to use the system. That's really the only area that I've been involved in to date.
It's something, something we need to. I guess, yes, it's all these things, isn't it? It's around what improvements and about all our users and ultimately what we need to be able to provide. I mean, just thinking about sort of on the TV, you get the sign language person in the corner, don't you? I mean,
yes,
who knows? I don't know, but
so I'll definitely take that one away.
Thank you. Thanks, Jackie.
No worries.
Okay, there's no other questions. We'll move on to Maxine, your health watch report.
Thank you. Thank you. I wrote this ages ago. It's like I got confused with the last. I thought, oh, it was coming up, that other one, but it was the annual report one.
Yeah,
that's right. Okay, so a few things. So for a little while now, I've been trying to review the trust board papers, particularly in relation to patient experience. I have been attempting to log in and view it on Teams, but the sound isn't always that great in this room. And it's quite difficult to pick up, and it's very challenging for me to attend to observe in person. So I'm largely kind of looking at the papers and doing my best to listen in on the meetings. That said, I did attempt some reflections from the September Trust Board papers, and in terms of patient experience, we picked up on 3 items which I outlined in the report. So around outpatient follow-ups, which John touched on, which was a view around group outpatient appointments, and a couple of instances around choking, aspiration, incidents and falls. So a couple of those, particularly the choke and aspiration and the falls, were they reflected some of the recent observations that one of the Health Watch Milton Keynes staff members made during some visits to the hospital as part of Milton Keynes Health and Care Partnerships like Improving System Flow project. So our Deputy CEO did some visits, talking to patients, covered quite a few wards over the week, but did notice some kind of risk situations with particularly patients nil by mouth that she found eating because they'd not been given the a few things like that. So it was interesting that had been picked up in the board paper, because she did notice some of those things prior to those being raised in the paper. So what we're doing with that, so she's taken that to patient experience team through patient experience family and experience board. And we have set up a meeting, I think next month, actually early next month, because we really do need to refresh and reformalise how we feed into the hospital and vice versa in terms of patient experience. We really haven't got it sorted since COVID. I think, you know, and that's a lot to do with certainly the pressures on the hospital as well. So we sent that feedback to that board, and it was presented when it was run a couple of weeks ago, and they were really appreciative of that. So I think it's kind of being able to get back into the hospital and speak to patients directly in the wards has really helped as well, because it's been quite a while since we've done that. So hopefully that's refreshed some relationships in that respect. I've shared a few experiences there. Again, that kind of highlights the story around BSL users in touch around difficulties accessing interpreters on the hospital site as BSL interpreters. And we are currently working with a small community group of BSL users as well, who are giving us some feedback. So hopefully we can use their insight to inform how accessibility can be improved in other areas as well. But yeah, so that's about me. If anybody has any questions, thank you very much.
It's really interesting, yeah, the way you make the connections as well as to whether or not that's something we've picked up.
Yeah,
You know, but
yeah,
flagging
that was
up
really interesting.
Yeah,
Actually.
yeah,
So,
which is good.
so it's good that you know, you can see it's already being worked on. It's already been highlighted and it's already being worked on. And if somebody goes in and then sees it, but independently without that knowledge, then it's good to see that, you know, we can triangulate that people are rating risk in the right way.
Yeah,
So, absolutely. To see.
Any questions for Maxine at all? Thank you very much. Thank you. Thanks for that report. It's really helpful. Babs, could I hand over to you for your lead governor report? That would be great.
Hi. Luckily for everyone attending, it's going to be quite short. So I'll give some time back to you all, but I'd like to obviously echo my sentiments made at the annual members meeting, welcoming our new governors, including obviously finding out today about Professor McWhinney, and hopefully I shall meet you face to face at some point in the near future. But really, in terms of my update, it's obviously a fairly busy time for the hospital. It's exciting time for governors in terms of things that are happening within the hospital and also in the community. Now, I have to be quite careful not to step on Louis' toes and sort of cover matters that are in his report. But I just want to sort of finish off by saying, well, in terms of the engagement, I'm pleased that us governors are able to get more involved. There's lots more to achieve for all of us. And personally, I know that I'm going to be setting aside some time in order to become more engaged in the opportunities that are coming forward for me and my fellow governors. Thank you.
Thanks, Babs. Any questions for Babs? Thank you very much. Moving on then to now Louis.
Rachel.
Oh, sorry, Rachel. Beg your pardon. You're on mute, Rachel.
Sorry. As a new governor, can I notice reference to a membership strategy? Where can I find that? And also, are there sort of objectives and or sort of KPIs in that sort of we refer back to and say, how are we doing as governors?
I'm not sure whether it's a question for me or for Louis and Kwame, because obviously in terms of the strategies that have been put together for our involvement and our engagement, a lot of that is formulated by them without lots of our input, and then obviously that's disseminated in meetings. But shall I, Kwame, you just come onto the screen?
Yeah, we developed a strategy last year, Louis, I think 2021, 2022, but we've completely overshot it. We've gone way beyond. So to share it now will not serve any purpose. I think what we're doing is we're waiting for the trust engagement strategy to be developed, and that's far advanced, and then so that we can shape it up to align and make sure that it's said properly. So, Rachel, I don't know whether you give us time to do that. but because what we have is what we have and what we presented to the council, we've completely overshot it. Yes, it's gone far beyond what we set out to do.
So what's the broad time scale of that, do you think, in terms of the trust strategy and then coming up with a membership strategy?
The trust strategy, Louis, I think they said December. Is it still December?
I think so, yeah.
So I will not be here. So it will be in Louis' sort of gift and the subsequent new trust secretary to push that forward. But the plan is that the trust secretary, once that's done, the trust version is done, then you can do a membership strategy that's aligned to the trust one. Because when we did it, there wasn't a trust one that was in place, so we did what we could with it. So it shouldn't take too long, I don't think, because it will be building up on what we had, what we plan to do. Yeah. So and make sure that it's aligned properly. Yeah.
Thanks.
Paul, I was just thinking where we're taking that with that draft strategy, where it will be going through in terms of our committees to have a look at, because I'm just thinking about keeping an eye on it. So I mean, Rachel's point, that is knowing roughly the time scale, because obviously we want to crack on with the membership engagement policy as well, or strategy.
Yeah, so the last time I caught up with Jacob, he said by December this year, but basically it's not. I don't think they've developed it enough for it to go to a committee yet. But but I think by December it should, if the way he described and the way Prime and Kate is also talking about it, if it's December, then it should, I don't know which committee it should go to, or maybe it should come to the council as well. Definitely the council. But I don't know which other committee that will, maybe the ILC as well, and the engagement board of course.
I was thinking around, about it, because that's very much around inclusion. But I mean, I can drop Jacob an email as well. I know you and Louis will be chatting with him, but I can drop him an email as well just to get some idea, so we can keep on top of monitoring the time frame. Rachel, did you want to add in?
It was only just one tiny point, Kwame. I wonder whether you can add me onto the engagement activity, because I was at the annual members meeting on the 9th of October.
Yeah, Louis, grab it, sort of make sure that, so we include her in all the activities.
Yeah, my bad, Rachel.
Thank you. Good stuff. Okay, Louis, on to your report.
Yeah, just a couple of things to pull out. In the reports, I reference a possible focus group at the local Gurdwara, which we've been able to confirm now for the 15th of November. So I will go down with a couple of staff members from Patient Experience, which is going to be really informative. We haven't done something like this either for Patient Experience or obviously within the community engagement side of the Council of Governors for, actually no one can remember the last time this happened, so that's really good. And also had a really encouraging conversation with someone who's a staff member and also a member of Milton Keynes Hindu Association since I wrote this report. And she's ultra keen to be able to organise an event or possibly more down at their community centre. She's really confident we could get a lot of people down there from their community. So I'm turning the wheels on that as well. So we're making some good progress with that. That's me.
That's good. And actually, I would like to acknowledge as well that through you and Kwame and the engagement that you've already done in the early stages with the Spinal Injuries Association, Yvonne and I have had a fantastic discussion today in terms of around some training that they can provide for our clinical staff. Looking after patients who come in with spinal injuries, and even though they may not be coming in for that specific area of their need, obviously they're coming for other medical needs, but obviously they must be looked after holistically. So there's, I know Yvonne was very excited about the work we can do with them. So some really strong partnership working there. And plus they have very good facilities for gatherings, conferences and stuff like that. So I'm looking in at it from that side as well. So thank you. It's just that this, you know, the effects and outcomes that we were hoping are beginning to bear fruit, I think. So thank you very much for the coordination, and thank you to governors as well for your involvement, and it is already making a big difference. So thank you. Any questions for Louis at all? No? Okay, thank you very much. Thanks, Louis. Going on to we need to approve the terms of reference. These have been looked at and consulted on. Does anybody want to raise any last minute thing on them, or are you happy to approve? Rachel? You're on mute again.
God, I'm so sorry. It's not about the amendments, but I did notice under membership, attendance and quorum, it lists the voting membership, but the chair of the trust is listed as a voting member there. And my understanding is that the chair is not a voting member of the council. Is that correct? I don't think the chair is actually a member of the council. You chair it, but I may be completely wrong, but I was just looking at the constitution.
I should be able to say immediately, shouldn't I? I must admit, because I've never had to be involved in the vote. It's completely escaped me. We can double check that. I mean, to be honest, from my perspective, that probably sounds right, is that I chair it, and I'm the link with the board.
I think I'd check back with the constitution, and the chair of the trust is not actually a council member, and so wouldn't have voting rights. So I think that bit of the terms of reference just needs to be amended there.
Thank you. Well spotted. Yeah. Okay. We can adjust that. I mean, but subject to that correction. Everybody happy with them? Gotcha. Any questions or motions from governors? Nothing's been flagged up with me, so I'm assuming everything's quiet on that. Thank you. And any other business at all?
Just do my normal thing, saying that we go around the wards as the friends of the hospital with a trolley, and it would be nice if I think it would be really good if governors came and actually saw what it's like on the wards at the busy time, especially in the mornings, and it gives a much better understanding of how the hospital works and has to cope with the situation like this at the moment and getting worse for winter.
Thanks. And I've been around with Claire, and like I say, it's a real eye opener. Actually, it's great to see. And I think I was pretty much incognito on the way around. I deliberately didn't. I had my pass on, but I deliberately didn't have my badge showing. So just felt that I was seeing things as they were, just going around the ward. So it is a great experience, and it does.
In fact, you even wore one of my shirts. Well,
it is.
Completely.
I'm completely incognito. Yeah. Anyway, it's a great way to spend the morning and to get them to know the hospital a bit better. And our forward agenda planner, any comments on that at all? I mean, obviously, it's always open to tweaking. If other topics come up, we feel that there's something significant we need to put in. But if everybody's happy, we'll leave it as it is for the time being. Thank you very much. And just the last thing that I would like to say, obviously, Kwame, you have mentioned that you won't be here. Moving on to Pastures New. He's been nabbed by another organisation. So Kwame, just to thank you very much for all your help and support and the work you've done. You and I both started together. So it's been an interesting, well, it could be nearly 3 years, won't it, by the time you move on. So thank you very much. And obviously, methods are afoot to find his replacement, but he's developed a team around him who I know will keep things going for us. So thanks, Kwame. All right.
Thanks, Kwame.
And the next meeting is 24th of January. 24th of January, yeah. Actually, it's 2024. So that's a bit scary. We're already talking about next year. So. And I hope to see as many of you as possible for that. But we will continue with the hybrid. I know it does help people to attend with busy schedules. So thank you all very much for your attendance. It's good to see you.
Right, thank you. Bye bye.
Cheers.